is a patient who has mesothelioma and is having a pleural biopsy. The preoperative diagnosis and postoperative diagnosis are both the same: right pleural effusion and suspected malignant mesothelioma. Now, we don't have a pathology report on this one, so we're just going to code it without the pathology report. It is possible that this might come back positive for malignant mesothelioma, but for this case, since we don't have the positive path report, we're not going to abstract that. The procedure, so this is a good jumping off point. So when they state what the procedure is, one of the good ways to start out is just read what this is, validate in the body of the operative report if this was actually done, or if they did actually do something additional, or if they changed it. Maybe it was a laparoscopic procedure that went to open, but we always use this as a great jumping off point. So this procedure was a right Vats, which is a video-assisted thoracic surgery, pleurodesis, and pleural biopsy. We have our anesthesia here, description of findings: right pleural effusion, firm nodules, diffuse scattered throughout the right pleura and diaphragmatic surface. Specimens: pleural biopsies for pathology and microbiology, estimated blood loss minimal. Fluids: crystalloid 1.2 liters and 1.9 liters of pleural effusion drained. So, indications briefly: this is a 66-year-old gentleman who has been transferred from an outside hospital after a pleural effusion had been drained and biopsies taken from the right chest that were thought to be consistent with mesothelioma. Upon transfer, he had a right pleural effusion demonstrated on x-ray, as well as some shortness of breath and dyspnea on exertion. The risk, benefits, and alternative to right Vats Pleurodesis and pleural biopsy were discussed with the patient and his family, and they wish to proceed. So oftentimes this indications for the surgery is just the history of what's going on and why they're going to be doing the surgery today. And then this is actually the details of everything that happened. So the provider should detail in here, everything that they did from start to finish, to when they were wheeled off into the recovery room. So after informed consent was obtained, the patient was brought to the operating room and placed in supine position. A double lumen endotracheal tube was placed. SCDs were also placed, and he was given preoperative Kefzol. The patient was then brought into the right side, up left decubitus position, and the area was prepped and draped in the usual fashion. A needle was inserted in the axillary line to determine position of the effusion. At this time, a 10 millimeter port was placed using the knife and bovicautery. The effusion was drained. So there we go. That's the actual procedure. They're draining it out by placing a sucker into this port site. Upon feeling the surface of the pleura, there were multiple firm nodules. An additional anterior port was then placed in a similar fashion. The effusion was then drained with a sucker. So again, we're doing more drainage of that fluid. Multiple pleural biopsies were taken with the biopsy device. So there's our biopsy. The biopsies that we're talking about here in this second part. Of note, feeling the diaphragmatic surface, it appeared that it was quite nodular, but these nodules felt as though they were on the other side of the diaphragm and not on the pleural surface of the diaphragm, concerning for a possibly metastatic disease. So that would mean it has spread out to other areas, metastatic. This will be worked up with further imaging study later on in the hospitalization, so they're not doing that yet during this encounter. After the effusion has been drained, 2 cans of talc pleurodesis aerosol were used to cover the lung and pleural surface with talc. So that's just kind of covering it up. The lungs were then inflated and noted to inflate well, so they're checking to make sure that they didn't puncture anything by accident, and they didn't. The lungs inflated appropriately. A 32 curved chest tube was placed and secured with nylon. The other port site was then closed at the level of fascia with 2O vicryl and 4O monocryl for the skin. Patient was then brought in the supine position and extubated and brought to the recovery room in stable condition. Dr. X was present for the entire procedure, was right Vats Pleurodesis and pleural biopsies. The counts were correct ×2 at the end of the case. So what are we looking for here? We are looking for the Vats Pleurodesis and potentially a pleural biopsy. And then our diagnosis, we're just going to use that right pleural effusion because it says here suspected, and we can't use suspected conditions for professional services. So we're just going to use right pleural effusion for our diagnosis. Okay. So let's start with the pleurodesis, and then we'll look at the pleural biopsy code. Now, when you're looking in your CPT book, I've talked in the past that there's two ways that you could do this. You could know that this is a lung procedure and start in your respiratory system and just look for the codes there, or you can go into your index and check in the alphabetic index, which is in the back for the CPT book. So here for the pleurodesis, we didn't do the installation of the agent. We did thoracoscopic 32650. And then next we need our pleural biopsy. And then we have biopsy. So you can see at the top here, these are our biopsies. And then this is for a biopsy of the pleura, and we have needle thoracoscopic and thoracotomy. So 32609 is thoracoscopic, which is what we did. So 32609. The others that we might want to look at, though, just in case, 32400, and then we have here the thoracotomy, which is 32098. We'll put a question mark there. So if we look at this VATS procedure here, 32650, it says here it's thoracoscopy surgical with pleurodesis, and that looks like exactly what we did. We did the thoracoscopy, it was surgical, and we did a pleurodesis. Now, when we take a look, though, at our biopsy code, 32609, that's actually over here, and that full description of this is the thoracoscopy, and then our semicolon. So thoracoscopy with biopsy of pleura. This isn't, first off, the surgical thing. And if you remember your guidelines for coding correctly, the surgical procedures always include the diagnostic. So in this case, I'm already starting to think this surgical code probably already includes this diagnostic biopsy. So I might be thinking, I don't think I want to bill that 32609, but there's ways we can check that. So let's go over those as well. And let's also take a look real quick at this 32400 and 32098, just to kind of make sure that we're ruling them out appropriately. So 32098 is down here. It's the thoracotomy with biopsy of pleura, and we didn't do a thoracotomy. And then 32400 is the biopsy of the pleural percutaneous needle, and we didn't use a percutaneous needle in this situation either. So I think that is a correct code for the biopsy. However, I do really feel like this is included in this, that this is all included because we did a surgical procedure. But how do we check that? So one of the first things we can do is check if you have access to a CCI edit checker, which basically tells you when you can or cannot bill certain procedures together. So this is Codify. It's the program that AAPC has. It's very reasonable to purchase certain types of ones, settings, lower grade ones that you can just kind of look up codes and check your edits in them. But if we put both these codes in here, the 32609, and see what it says in the CCI edit checker, it gives us an indication saying here that code 32609 is a column 2 code, so you can't override the edit. And that basically means that we can't bill these together. If we look at this code, the surgical code here too, this has a higher RVU, it's higher reimbursed, so we're definitely going to bill this procedure and leave this procedure out. Now, if you're not familiar with the CCI edits, I can kind of show you a little bit of what those look like as well. So here is actually where you download the files from the CMS website. Right now we're looking at practitioner, not hospital, because we're not billing for the hospital services, we're billing for practitioner. And these are for January 1st, 2021, and we're not quite there yet. So I want to be looking at the ones for October 1st, 2020, and here's what they look like when you open up the files. So this is the CCI column 1, column 2 procedure to procedure edits. And if you look here, it tells you that a 0 in this column indicates that a modifier is not allowed, meaning you can never bill the column 1 code and column 2 code together. Here it says also the 1 isn't allowed, meaning sometimes in certain cases you can bill them together, and 9 is not applicable. So let's quick take a look at our procedure, our column 1, our big surgical procedure, our 32650. I'm going to do a search for that. And it'll pop me down here, and I'm looking for my second code, which would be in column 2, that 32609. So 32609 is here. Here's our primary code, 32650, 32609. And you can see there is the 0 in that column indicating that a modifier is not allowed, meaning that we cannot use a modifier to unbundle these procedures and say, hey, there was a certain circumstance that we should be billing these together. It's not allowed. We cannot bill these two codes together. The CCI Edit Policy Manual is also on the CMS website, so you can just scroll down here and you download it here, NCCI Policy Manual for Medicare Services. So this is the 30,000 code range, and if we do here our Control F and we search for VATS, it says right here, a diagnostic biopsy of the lung from an anatomic location removed during a more extensive procedure, and one of the examples it gives here is the VATS procedure, at the same patient encounter is not separately reportable with the more extensive procedure. So we're just billing this more extensive procedure because this biopsy is not separately reportable, so we can't report both of them. So in that case, we're just going to bill the procedure code that we had indicated, this 32650. Now, of course, lastly, we need our diagnosis code for our pleural effusion. So here is our effusion. And we have, let's see here, pleural. We do have different types of pleural effusions, but it doesn't look like we have any specificity as far as any of these influenza, malignant. Does it say malignant pleural effusion? Let's double check, because there was some consistency, some comments here about malignant mesothelioma was suspected, but it really didn't say that the effusion was necessarily malignant. So this is probably not going to be coded to that level of specificity. So we have pleura J90. So we'll write that down here and we'll check that in our tabular list. So here we have it, J90 pleural effusion, not elsewhere classified. That's what we've got. NOS, not otherwise specified, included pleural effusion. So we've got this. We've got our 32650 for our CPT, for our procedural code, and then J90 is our diagnosis code. I hope you guys found this video helpful. If you did, don't forget to give it a thumbs up to support the channel. And I would really encourage you to subscribe and hit the notification bell so you get alerts when I post new episodes. I will see you guys in the next episode. And until then, keep on coding on.